Right. Can you guys hear me? Can I see some faces? Okay. Guys, at least a few of y'all, yeah, turn on your cameras. Otherwise, I'm teaching to some black screens. Okay, so how is everyone? After a long time, students, I heard a lot of students are going for hospital rounds now. Be careful. Right. Okay, guys. So welcome to the rheumatology module. Now, for those of you all who are new here, I think we have a few new faces, right, joining in today. I'm Prashan, and we've Medicine 101 just passed its first birthday, 1 year. We surpassed 1 year. So this is our sixth teaching module, sixth lecture module. I know some students here who have been here from the first one. Right. So let's get started. We are starting off rheumatology today, right? And it's a free session. If you all have any friends or anyone who wants to join, just share the link with them. Right, guys. Okay. Firstly, can someone tell me what is rheumatology? Just to get things going until I share the screen. What is rheumatology? What do you all know about rheumatology? Anyone? Anything about rheumatology? Nothing? What does rheumatology involve, guys? What are we studying? What are we studying?
Autoimmune conditions.
Bones.
Right.
Soft tissues.
Yes, basically, guys, we are talking about joints, right? We are talking about joints, and this includes a lot of conditions, starting from mechanical injuries. We are going to go to autoimmune conditions, a lot of things, right? But basically, rheumatology is surrounding joints, right? Okay, then we'll get some terms out of the way. What do you all know about the term arthritis? Arthritis, right? What is arthritis? What is arthritis?
Inflammation of the joints.
Inflammation of the joints. We usually say inflammation of one or more joints, right? Greater than or equal to one joint. This arthritis, guys, this is an umbrella term. Why do I say that, right? Anything, any condition, any disease that causes at least a mild inflammation of your joint, you can put under this arthritis, right? So there is over 100 different conditions. Everything comes under arthritis. So therefore, when there is inflammation, what are the main signs of inflammation, guys? What are the cardinal signs of inflammation?
Fever,
Redness.
redness, swelling.
Did someone say fever? No, right? I thought I heard fever. Okay, so yeah, redness, swelling. What else?
Pain.
Pain, yes. Calor. What is calor?
Heat.
Increased. Yeah, heat production, right? Yes. And what is the last one? Loss of function. Loss of function, right? Okay, excellent. So since arthritic conditions have some sort of inflammation, right, there may or may not be these signs visible, right? Why I say may or may not? Because the degree of inflammation can vary, right, from one condition to the other. Okay, having said that, guys, we will classify arthritis like this, right? You all can write these down. How we classify arthritis is, guys, we are still using this. There are actually multiple classifications, right? We will use this one. This is the most commonly utilized one, right? This one, guys, it has changed now a bit. It used to be called mechanical arthritis, and inflammatory arthritis. Right? Now, this was the traditional one, right? Now, what we did is, guys, we added 3 letters. To this mechanical part, we put bio in front, right? Now, this is classified as biomechanical arthritis versus inflammatory arthritis. I will tell you all why, right? Why this is, guys? Mechanical arthritis, what we first, what we believed was, what scientists believed was, this is just mechanical wear and tear, right? With age, with various risk factors, we are going to talk about all the risk factors. They just believed, right, the articular surfaces of joints, right, they just underwent wear and tear. That's what they believed at first. right? Later, right, more recently, what we found out was inflammation also plays a role in mechanical arthritis, right? So this is what I want you all to know here for the first point. There is some inflammation in mechanical arthritis as well, but just write down minimal inflammation, right? There is minimal inflammation. Inflammatory arthritis, guys, on the other hand, there is severe inflammation. Okay, right? Okay, right. Now, when we look at the examples, guys, for biomechanical arthritis, one of the examples is trauma-induced, right? It can be a fracture through the articular surfaces, previous surgical procedures at the articular surfaces, anything, right? Trauma-induced, right? Then, guys, in the previous module, students who came for the previous module, under diabetes, do you all remember any sort of rheumatology, joint related problem that is coming up? What was it called? Unmute and say. I think Sasanga taught you all this chapter. Any neuroarthropathies that you all remember? What neuro? Yes, excellent. Charcot's, right? Charcot's neuroarthropathy, right? Neuroarthropathy, right? This also comes under this biomechanical, right? So we are not going to talk about these. We've already talked about. And the third one is, guys, osteoarthritis. This is what we are going to discuss today, right? Then on the inflammatory side, when we look at the inflammatory side, right, we can break this down into two, guys. We are not going to discuss these in depth, but just to get over with the classification, erosive arthritis, right? Erosive arthritis and infective arthritis, right? Under erosive, guys, right, we are going to get rheumatoid arthritis, gout, right? Gout, psoriatic arthritis, right? Ankylosing spondylitis, all of these different things, these will be taught in the upcoming lectures, right? Don't worry. Under infective arthritis, right? This is under surgery, guys. This topic is under surgery. Have any of you all heard something called pot disease? What is pot disease?
TB related.
Yes, TB of the what?
Spine.
Excellent. Yes, this is TB of the spine, right? TB of spine. Okay, tuberculosis of the spine, right? Pot disease. These are surgical topic, guys. We are not going to talk about this, but all these erosive arthritis, these will be discussed in the upcoming chapters in our module, right? Okay. Now, osteoarthritis. This is today's topic, guys. This is what we are going to dive into, right? Today's topic. Write this in big letters, right? Let's take this. Osteoarthritis. Right. Now, what does osteoarthritis mean? Just from the name, Look at this, guys. Osteo, anything osteo means what? Bone related, right? Bone related, right? Arthur, right? Arthur, you can say, Arthur, not Arthur, right? This is what? This is anything joint related. Right. Yes, joint related. Itis is what? Inflammation, right? Inflammation, right? So what is this? Inflammation of the joints and the bones. Part of the bone also we will see. There can be some inflammatory changes. We will see in the pathophysiology, right? Now, the first point I want you all to know, guys, this is the most common form of arthritis, right? This is the most common form of arthritis. Now, in the upcoming chapters, we always discuss various types of arthritis. When you all hear osteoarthritis, I want you all to repeat in your minds joint failure, right? Joint failure, right? Okay. Osteoarthritis, joint failure. Okay. Because of this, guys, this one is given another name, degenerative joint disease. Okay. Now, just from the naming, I hope you all are getting some idea, right, where this disease is going, right? What I want you all to know, guys, this is a chronic progressive disease, right? Chronic progressive disease where almost all structures of the joint undergo pathologic change, right? This is a chronic progressive disease where almost all structures of the joint undergo pathologic change, right? We will see what is happening, right? Now, so what are we saying? This is joint failure. So if we want to know what a failed joint means, what should we first do? We should first know what a normal joint is, right? Normal joint is. Now, joints, guys, there are multiple types. Osteoarthritis, 99.99% of the cases, right, affects synovial joints. Synovial joints. Okay, synovial joints. So let's, in your skeletal notes, I have put a picture for y'all. Let's take a look at this synovial joint and just get an idea of what the parts are, right? Okay. Right, let's look at this. So here we have the two bones, guys. Okay, we have the two bones and the synovial joint. Let's see what are the structures here. Firstly, guys, in this bone, let's just go through that as well. What is this part, guys? What is this part? You all know parts of a bone. What is this? What is this? Epiphysis, sorry? Is this epiphysis? Yeah, okay. Right, this is the epiphysis, right? Epiphysis. Okay, then we have, what is this one? What is this one? Metaphysis, right? This is the metaphysis, right? And this innermost one, right, towards the middle of the bone, right, towards the middle of, yes, this is diaphysis, right? Diaphysis, sorry, DIA, right? Diaphysis, right? Now look at this, guys. Between the epiphysis and the metaphysis, there is a small space here. What is this? What is this space, this small space here? What is this?
Epiphyseal plate.
Yes, this is the epiphyseal growth plate, right? The epiphyseal growth plate. Epiphyseal growth plate. Now, you all know the epiphyseal growth plate, it closes after some times, right? After some time, it closes in humans. When does it close? When does it close?
After puberty.
Yes, at the end of, towards the end of puberty, the epiphyseal growth plate closes. What do we mean by the growth plate closing, guys? This gap becomes smaller and smaller and smaller and smaller until there is no gap, right? No gap there. Okay. Now, so therefore, this bone, this joint structure here that we have drawn, most likely whose? Is this a 20, maybe let's say 16-year-old boy or a 70-year-old man? Whose joint is this?
16.
Yeah, okay. It's most likely a younger individual because the epiphyseal growth plate is there, right? Okay, that's basically the bone. Now we come to the important points. Look at this. This blue structure here, right? This is our articular cartilage. Articular cartilage, right? In synovial joints, guys, the articular cartilage is made up of a material called hyaline, right? It is made up of a material called hyaline, right? Okay, this is a very glass, or sometimes we say it is a porcelain-like substance, right? We'll see. It is very smooth, right? Okay. Then, guys, what about this structure here? What is this structure? What is this structure? This yellowish structure.
Synovial membrane.
Excellent. This is the synovium or the synovial membrane. Synovial membrane, same thing. Synovial membrane. For now, just know, guys, we'll look at the histology later, right? When we are talking about the disease. For now, just know this inner membrane of the synovium is lined by some cells, right? We'll talk about these different types of cells, and they produce synovial fluid into this joint space, right? So in this joint, this is the joint space. In the joint space, it will be bathed by synovial fluid, right? Synovial fluid. Okay, synovial fluid. Then what is this outermost one, guys? This purple capsule sort of thing? What is this? Okay, I think I gave it away. What is
Articular
it?
capsule.
Yeah, we usually call this a joint capsule. Joint capsule, right? Okay. Right. Then what is this structure, guys? This structure here. What is this? What is this? Now just note, you just from the diagram, what can you see? It looks like it has a similar structure as the synovial membrane, correct? So what do you think it is?
Bursa.
Yes, these are, guys, fluid-filled sacs. They are also lined by synovial membrane, and we call these bursa, right? We call these bursa, right? These are basically supportive structures, guys. It gives a cushion-like effect for the joint, right? And helps reduce friction, right? Okay, that is the bursa, right? Then the next thing I want you to look at this bone here, guys. You all can take another color or something and just color this area, the bone that is just underneath the cartilage, right? The bone that is just underneath the cartilage. We give this bone a special name, guys. We call this subcortical bone, right? Subcortical bone, right? Now these terms are important because when we come to the pathophysiology, when I say there is subcortical bone sclerosis, I want you all to understand where that is. Okay, subcortical bone. This is subcortical bone. Okay, right. Okay, then tell me. Okay, this is a muscle. This is a muscle. This is obvious to everyone. What connects a muscle to a bone, guys? What connects a muscle to a bone? These are basic questions.
Ligament.
What connects a muscle to a bone?
Ligament.
Ligament
Tendons.
connect tendons. Ligaments connect bone to a bone. This is a ligament here, right? Ligament here. Okay. Right. Now, an important thing I want you all to know. This synovium, the synovium, right? You all can take a red pen or something, right? And draw a nice vasculature. This synovium, guys, it has a nice vascular supply, right? It has a nice vascular supply. At the same time, it also has a nice lymphatic drainage. It has a nice lymphatic drainage, right? This synovium, the synovium. As opposed to that, what do you all think about the cartilage, guys? This hyaline cartilage, this articular cartilage, does it have a blood supply? What do you all think? Answer. Hyaline cartilage, does it have blood supply? No. Okay, no, right? Good. Hyaline cartilage, guys, it is avascular and aneural. Avascular and aneural. Okay, write that down. Avascular and aneural. Therefore, if the hyaline cartilage is avascular and aneural, where does it get its nutrition from? Where does the hyaline cartilage get its nutrition from?
Synovial fluid.
Right.
No?
Let's go the other way. From the subcortical bone, guys. You all know bones have a nice blood supply as well, right? Bones have a nice blood supply as well. So from this subcortical bone, right, the cartilage gets it nutrition, right? Nutrition. Okay. Right. Then the next thing I want you all to know, guys, there are some nervous tissues attached here as well. You all can take a yellow color maybe, and you all can draw, right? There are some nervous tissues to the synovium, right? To the adjacent ligaments, to the adjacent bone, right? All of these structures have nerve supply, guys. Now, one type of nervous receptors that are present here is, guys, nociceptors, right? Nociceptors. These are what? These are responsive for noxious stimuli. You all know, right? Whenever danger is sensed, right? These are the ones that start firing, right? These play an important role in pain pathways as well, right? We will talk about this, especially when we come to the management part, right? It is important to discuss these nociceptors, right? Then another type, guys, look at this. This one is also very important. Again, to all of these structures, adjacent structures, except the cartilage, right? Mechanoreceptors. We have some mechanoreceptors, right? Mechanoreceptors. These ones, guys, basically they are sensitive to stretch, right? They are sensitive to stretch, right? Let's see what they do, right? When we come to the joint protective mechanisms, let's see how they function. Okay, is this clear? Right? So these are the basic structures I want you all to have an idea about. Okay. Now, if you all notice, guys, I have drawn a gap between these two cartilages, right? Actually, between the cartilages, guys, there is not much of a gap, right? There is only a very thin layer of synovial fluid. I have drawn it here, exaggerated for us to get a clearer picture. But usually these articular cartilages are touching together, almost touching together. There is a very thin layer of synovial fluid passing through. For example, guys, if you all think about the knee joint, right? This amount of synovial fluid at the knee joint is about somewhere between 1 to 4 milliliters, right? That's it. That's it, right? It's like 4 drops of water. Okay, that's in the knee joint, right? So there's a very thin layer, very thin layer. Let's see how it works. Okay, right. Then, now that that's out of the way, one more thing we need to talk, guys, before we go into this, right? Osteoarthritis. How do we classify osteoarthritis, right? Osteoarthritis, guys, we mainly classify into two: primary and secondary. Primary osteoarthritis and secondary osteoarthritis, right? Under primary, guys, okay, these are the ones we generally cannot reverse, right? When we are talking about management, for example, these are idiopathic. It can be idiopathic. We don't know why it's happening, or it can be age related, right? Due to senile changes, right? We'll see all of these in the pathophysiology, right? Then, guys, there is another one called generalized osteoarthritis, right? And there is another one, guys, called erosive osteoarthritis. Erosive osteoarthritis. This is a subtype of osteoarthritis of the hand. We will talk about this. Don't confuse this with erosive arthritis. This is very important. Erosive arthritis is different from erosive osteoarthritis. Okay, right? We will talk about this when we talk about hand osteoarthritis, right? Erosive osteoarthritis, right? Then secondary, guys, what do we usually, any disease in our body, if we say secondary, what does it mean? There is usually some other disease or some other cause that is giving rise to this disease, correct? Right? So here it's the same thing. Secondary osteoarthritis means due to other conditions, guys, usually, right? There can be due to congenital anatomical abnormalities. We'll talk about all of these, anatomical abnormalities, right? There can be any other disease of the joint, guys, any other disease of the joint. For example, all the other chapters that we are going to discuss in this module, right? They can increase the risk of secondary osteoarthritis, right? Rheumatoid arthritis, gout, right? Or any endocrine pathologies, diabetes mellitus, right? All of these things. And then trauma or injury, right? Trauma or injury. These give rise to secondary osteoarthritis. Okay. This is the general classification I want you all to know, right? Right. Now, look at this, guys. Why do you think we as humans get osteoarthritis? That's the question of the century. Why do we get osteoarthritis? Right? We're so unlucky. Okay. Here's the thing, guys. So our limbs, right, were designed from an evolutionary perspective, right? Our limbs were designed for whom? For brachiating apes, right? These are animals who walked on all four legs and they swung from tree to tree, right? Our limbs were designed for these. Then what did we do with evolution? With evolution, what did we do? We started standing from both legs. We started getting a position of our thumbs. We were able to do this pincer grasp and all of these things, So what happened? We stood out from the rest of the animal kingdom. We were like, you can't do this, but I can, right? But what happened? It came with a side effect. What is the side effect? These joints were not evolved enough to handle these kinds of movements. Okay, so the side effect is osteoarthritis. Okay, osteoarthritis. Now, commonly affected guys, because of this reason, because of this reason, the commonly affected ones are these joints that we abnormally use. Instead of walking on 4 legs, we walk on 2 legs. So what is happening? Knee, right? Knee osteoarthritis, very common, right? Hip, same thing. Hip osteoarthritis. Okay, knee, hip, right? And then our hands, especially guys, our first carpometacarpal joint, this joint here, the first carpometacarpal joint, right? This is another place in our hand osteoarthritis, right? So that is also due to our opposition ability, right? Opposable thumbs. Okay. And then guys, a little bit rarer than these three, right? We have spinal osteoarthritis and shoulder osteoarthritis. Spine guys, usually to the cervical spine and lumbosacral spine. Okay. And then rarely guys, shoulder osteoarthritis as well, not very common, but shoulder osteoarthritis as well. These are the main types of osteoarthritis that humans suffer from. Okay, humans suffer from, right? Commonly spared guys are the wrists, elbows, and ankles, right? Wrists, elbows, and ankles. These are commonly spared for osteoarthritis, right? Okay. Right. Okay. Now don't send me messages later, disproving evolution or anything. I have no bias, okay, towards anything, right? So this is a logical way to understand. Okay, logical way to understand. Right. Let's go for the next thing. Now, what is the general progression of this disease? What is it like? Look at this, guys. There are first going to be some risk factors, right? Some risk factors. We'll talk about them, right? These risk factors, guys, they are going to alter, right? These risk factors, they are going to render our joint. There is something called joint protective mechanisms. Joint protective mechanisms dysfunctional, right? Dysfunctional. Okay, we'll see what these joint protective mechanisms are. Don't worry. Right? So joint protective mechanisms will be rendered dysfunctional. Then what happens, guys? This is when the protective mechanisms are gone, that's when we get joint pathological changes. Pathological changes. And that leads to osteoarthritis. Right? And this osteoarthritis, guys, it can be early, it can be mild or moderate, and it can be advanced disease. We'll talk about all of these. Don't worry about that. First of all, even before we discuss the risk factors, let's look at the normal physiology. What do we mean by normal physiology? What are these joint protective mechanisms, right? How do they work in our normal body, right? This is what we are first going to look at, right? So you all can put a topic, joint protective mechanisms, right? Joint protective mechanisms, right? Okay. Right. Okay. Look at this, guys. First one, right? First one, articular cartilage, right? Articular cartilage. So in terms of our chapter, osteoarthritis, we are talking about articular cartilage of synovial joints, and therefore we are talking about hyaline articular cartilage, hyaline articular cartilage, right? This hyaline articular cartilage, first let's take a small idea about this hyaline. What is this hyaline? This is the most abundant or widespread human cartilage, right? Hyaline cartilage. Apart from this, what are the other types of cartilage? We have something called fibrocartilage. We have another thing called elastic cartilage, right? Your ears, the pinna of your ears, this is made up of elastic cartilage, right? This is why you can bend your ears like that. Then if you look at fibrocartilage, your pubic symphysis, right, your spine, these structures are made up of fibrocartilage. And these articular surfaces of synovial joints are made up of hyaline cartilage, right? Actually, guys, during your development, in your embryonic stages, right, hyaline cartilage is the one that first forms in your body, right? And then they can undergo ossification and everything and become bones, right? Okay, so this makes up your embryonic skeleton, hyaline, right? And then it can be substituted into other forms of cartilage, or it can ossify, right? And in adults, it persists where? At the end of long bones, at the ends of long bones. So that's what we are going to talk about now, right? This one is, guys, hyaline, this structure is glass or porcelain like, right? Glass or porcelain like. It's a very, imagine like a shiny, I have a video, I will show it to you today at the end of the class. It looks like a very shiny structure, right? Very smooth, very shiny, okay? Then write this down, right? This is, don't forget this, aneural and avascular, right? We have already talked about this, aneural and avascular. Okay, what about the composition, guys? What is this made up of, right? Articular cartilage, what is it made up of? This is made up of mainly two things, guys. Look at this, chondrocytes, okay, chondrocytes, and extracellular matrix. Extracellular matrix. We'll look at this structure, right? Draw it like this, guys. Let's take a small box, right? Now, if this was a bone somewhere here, and let's say we have the cartilage on top of that, right? We are going to take a small piece here, right? And look at this. We're going to take a small piece from there and look at it, right? So it's going to look something like this. This is the cartilage piece. Okay, something like that. Okay, look at this, guys. Firstly, we have this main cell type, right, which are called chondrocytes. So you all can draw a few chondrocytes. These chondrocytes, guys, right? Look at this. It's like this, right? Randomly, you all can draw. And these chondrocytes, guys, they are separated from the rest of the extracellular matrix by this membranous, thin membranous structure called lacuna, right? Like this, something like this. Okay. Within one lacuna, guys, there can be up to 8 chondrocytes. Now I have drawn only one chondrocytes within the lacuna, but you all can draw more, right? There can be up to 8 like this, right? It's like they come like in packs of chondrocytes. Okay, something like this, right? Okay, right? So these are the chondrocytes and the lacuna around them. Now, the chondrocytes itself, guys, they produce the extracellular matrix, right? Extracellular matrix. What is in this extracellular matrix? Let's look at it. First thing, guys, right? You all can draw long strands like this. What are these? What type of collagen is mainly found in hyaline cartilage, guys?
Type 2.
Excellent. Did I hear something else? Type 2, huh? Type 2 collagen mainly in hyaline cartilage, right? Look at this. So these are, I'm drawing these collagen strands. You all also can draw it like that, right? Collagen strands intertwined with each other, right? There is no proper arrangement, guys. They are haphazardly arranged like this, right? Collagen strands. These are type 2 collagen, right? Type 2 collagen. Okay. Type 2 collagen. Okay. Then, so this, now who produces this type 2 collagen? Chondrocytes, chondrocytes. Chondrocyte itself produces all of these. The next structure of the extracellular matrix. We have type 2 collagen. We also have some, you all can draw another color maybe, right? Some other strands like this, right? These are, guys, elastins, right? These are a type of proteins as well, right? Elastins, right? Elastins. Elastin, okay, elastin fibers. Then the next thing, guys, are some centipedes. You all can draw something like this, We will zoom into these structures and look. This is some centipedes. What are these centipedes? These centipedes are called, let me draw a few of them. Right, y'all can just draw multiple, right? These centipedes, guys, these are proteoglycans. Okay, right? We name the lacuna here, right? These are proteoglycans. Don't worry, we'll look at the structure. Now this entire thing, guys, this entire thing is bathed in water. Right? So y'all can color it something like that, right? This is the structure of our cartilage, of our hyaline cartilage, right? Okay, now look at this. What are these proteoglycans? Now, the other ones are obvious. Look at this, guys. Collagen. When we have type 2 collagen, right, tightly intertwined, right, structurally arranged, holding everything in place, what does it do, guys? It helps to increase tensile strength. Right? Elastin. What do you think elastin does? Increases flexibility. Right? What do these proteoglycans do? Let's look at this. This proteoglycan, guys, this centipede-like structure, right? If we actually zoom into it and look, it will look something like this, right? Something like this. You all can draw, right? You all can draw this, huh? Right? It looks something like this. What is this structure? Let's look at it, guys. This middle, the main body, this is hyaluronic acid, guys. Hyaluronic acid, right? Hyaluronic acid molecule. This is one molecule of hyaluronic acid, right? This makes up the body of the proteoglycan, right? Then we have these small circular or ball-like structures. These are some linker proteins, guys. Linker proteins. They link something onto the hyaluronic acid, right? What do they link onto this hyaluronic acid, guys? These ones are called protein co-proteins, right? We'll see what these are, right? Don't worry, just write it down. Hyaluronic acid contains some linker proteins, and linker protein is connected to a co-protein. This co-protein, guys, that is filled with an abundant amount of structures like this. You all can draw it like this, huh? Right? Okay, now really looks like a centipede, no? Right? What are these, guys? These are glycosaminoglycans. These are glycosaminoglycans, right? Glycosaminoglycans. What are these glycosaminoglycans, guys? Basically, have we all heard? One of them is chondroitin sulfate, right? And another one that is here is keratin sulfate, right? Keratin sulfate. Okay. Either one can be there, right? Both are there in mix, right? Now, what I want you all to understand here, these glycosaminoglycans that are present on the co-protein, these are heavily negatively charged, guys. Very highly negatively charged structures, these glycosaminoglycans, right? They are highly negatively charged structures like this, right? And when they are present in the extracellular matrix, guys, now we have drawn here, how many have I drawn? 1, 2, 3, 4, 5, 6, 7, 8, 9. I have drawn like 9 proteoglycans in this structure, right? But actually, guys, within a very small space, there is going to be hundreds of thousands of proteoglycans packed together, right? And if you, now here we drew the structure a little spread apart for easy identification. If you actually look at it, guys, it looks something like this. There are no these large gaps between these core proteins, right? They look something like this. So if they're highly negatively charged like this, if they're tightly packed together, what do you think is the function of this proteoglycan in the cartilage? They're highly negatively charged, tightly, closely packed together. What is the function? Try to imagine, be creative. Tell me, just guess and tell me. If you take a lot of negatively charged particles, put them close together, what do you think is going to happen?
Repel.
Repel.
Excellent. There is electrostatic repulsion. This gives, guys, now imagine this is your cartilage, right? Okay. And then when there is some shock, when there is some pressure, it will pinch a little bit inward, but due to the repulsive forces, what will happen? Bounce back to the normal structure, right? So this, due to the electronegative repulsive forces, proteoglycans, guys, they give what we call compressive stiffness or shock absorption property, right, of our cartilage. Very, very important structure in our cartilage. Okay, right? It gives the compressive stiffness or the shock absorption property, right? Okay. Now just based on this, still we haven't discussed anything about osteoarthritis, right? Okay, but just based on this, I'm telling you all, there is one treatment protocol. We have not even stepped into treatment. We are a long way from treatment. There is one treatment protocol called injections of hyaluronic acid into the joint space. Now, do you all understand what that's going to do? Why there are injections of hyaluronic acid? Okay, so when we come to the treatment part, we'll look at that. Okay, very important structure, right? Now, just before we move on from this, guys, this core protein with the glycosaminoglycans, these two structures together, the core protein with the glycosaminoglycan, these two together are given a special name, guys. It is called aggrecan. Okay, these are called aggrecan molecules. Okay, right? Aggrecan molecules. Then the aggrecan molecules collectively, together with hyaluronic acid, this entire structure, right? Basically, this is our proteoglycan, which we called an aggrecan aggregate, right? This is an aggregate of aggrecans, right? Okay, I know these words. So when you all read Harrison's or when you all read Kumar and Clark, when you all come and don't get scared. Aggrecan aggregate, they will say. Okay, this is basically our proteoglycan. Okay, an aggregate of aggrecan. Okay, right? Now look at this, guys. So this is the entire structure of this extracellular matrix, right? Chondrocytes have the function of secreting, right? You all know chondrocytes, right? This is the next point I want you all to know. Chondrocytes, right? They produce extracellular matrix. So basically, when we are producing extracellular matrix, what are we doing, guys? We are producing new cartilage. Everyone agrees with me, right? When we are producing new extracellular matrix, we are basically producing new cartilage, right? So our chondrocytes are doing that. Then chondrocytes also have another function, guys. What is that? Degrading old extracellular matrix. Degrading extracellular matrix, basically, guys, breakdown of old cartilage. So what is the chondrocyte's function? Basically, guys, this is a dynamic balance. This guy maintains this balance, right? It's an equilibrium, right, between production of new cartilage and breakdown of old cartilage. This breakdown, the breakdown process, guys, we call it catabolism, right? Right? And the synthetic function we call it anabolism. Anabolism, right? So this is in a dynamic balance and it is maintained by our chondrocytes. Okay, chondrocytes. Right. So did everyone understand the first joint protective mechanism? Right. It's cartilage, articular cartilage, hyaline cartilage. Now, what I want you all to understand here, guys, this structure that we drew here, right? This is hyaline articular cartilage, specifically of synovial joints, right? Hyaline cartilage, guys, they are present in other areas as well. For example, our trachea, our ribs, right? In these areas, these structures can vary a little bit. Okay, can vary a little bit. For example, here we don't find chondroblasts, right? But in some other structures of hyaline cartilage, we can find chondroblasts as well, right? Here we find only chondrocytes, right? Okay, so there can be differences like that. Don't get confused if you all go and read about hyaline in general, right? This is specifically, we discussed hyaline in articular cartilage of long bones, okay? Right? Right. Let's move on to the second one. What's the second joint protective mechanism? This is another very important one. What is this? Synovial fluid. Synovial fluid. Look at this, guys. Synovial fluid. What is this synovial fluid? Synovial fluid, guys, you all can write this down. I'm not going to write everything. You all can write it down. This is straw colored and clear. It is straw colored and clear, right? The way you can imagine this is, guys, it is egg white like, right? We say egg white like, okay, appearance, consistency, egg white like consistency, right? What I want you all to know here, write this down. Secreted by whom? Secreted by type B synoviocytes. Synoviocytes. Now, don't get scared of the name. Let's look at what we mean by this, right? Secreted by type B synoviocytes, right? Look at this, guys. Let's take a bone. Right, and let's take a articular region of a bone, of a joint, and you all know the synovial membrane is something like this, right? Synovial membrane, something like this. Let's take a small piece out of here and look at this structure, right? You can draw it maybe in a box. Okay. Right? Okay. Let's look at this. Right? This is going to look something like this, guys. Now let me draw it like this. Better to draw it like that. Okay. All right. Now you all know in this synovial, in this joint space, this area is full of synovial fluid, right? This light blue highlight, right? That area is full of synovial fluid, right? Now look at this, guys. So this light blue fluid here is synovial fluid, right? Synovial fluid. Okay. The synovium, guys, the synovium mainly has two different types of cells, right? Synovium is made up of two different types of cells. You all can draw one in dark purple or any color. You all can use any color you all want, right? Something like this. And the second type of cells, draw it in this color, right? Something like this. Okay. The intimal layer of the synovial membrane contains two different types of cells, right? We'll look at these two different types of cells. But before that, what do you all know about the synovial membrane already? Does it have a blood supply or not?
Yes.
It does, right? It does. I saw some of you are doing this. That is cartilage. That is cartilage. This is synovial membrane. Okay, right? It does have a blood supply and it does have a good lymphatic supply as well, right? Nice blood supply and a nice lymphatic drainage, right? Okay, something like this. Now look at this, guys. We'll look at these two different types of cells. This dark one, we'll call it the type A cell, type A synoviocytes, right? Synoviocytes, type A cell. And this red one is the type B, right? This type A synoviocytes, guys. Type A synoviocytes. These are derived from some WBC, especially from monocytes, guys. Right? These are derived from monocytes. So they have a WBC-like function. What do they do? Right? They clear out. Right? Now let's imagine this synovial fluid, if it has any debris, right? This synovial fluid, if it has any debris, the type A cell will engulf that debris and clear it out. Right? So it clears any wear and tear debris coming from your cartilages. Right? It clears any wear and tear debris. Clears debris, right? Type B cell, guys, what's the function? Produces synovial fluid, right? Type B cells will produce synovial fluid. Okay, right? Now, what does this synovial fluid contain, guys? What does this synovial fluid contain, right? This synovial fluid, guys, it's a little bit similar to our extracellular fluid, right? Extracellular fluid, it's a little bit similar, but the viscosity and everything is a little bit different. It is a little highly viscous. But basically, look at this. It contains hyaluronic acid. It contains hyaluronic acid. It contains something called lubricine. Lubricine, right? This is another glycoprotein, guys. Another glycoprotein, right? Helps with lubrication function, right? And then apart from that, it contains some enzymes, some proteinases, right? Some collagenases, right? To break down excess substances that are not required, right? These things are there, right? This hyaluronic acid here, guys, this fellow is important to maintain high viscosity, right? In our joint, guys. Now imagine you have some, let's say coconut oil, right? You have some coconut oil, and then you have in another cup, a cup of water, right? Okay. If you want to lubricate something, which one will you use? The higher viscosity coconut oil or the water? If you want to lubricate something, maybe two pieces of metal or something that are joined together, which one will you use?
Oil.
Yeah, we will definitely go for the oil. Same thing here, guys. This hyaluronic acid, it has a very high viscosity, right? So it helps with reduction of friction, right? It helps with reduction of friction. Okay. Actually, guys, the function of this synovial fluid, right, is very, very complex than what we know, right? We think it's just a fluid that helps with everything, which helps reduce friction. Actually, guys, it is called a rheopexic fluid. Synovial fluid is a non-Newtonian fluid. If anyone is interested, drop me a message after class. No need to talk about that now, right? If you all are interested, let me know, right? Just drop me a message, right? It is a non-Newtonian fluid, right? It doesn't obey the laws of Newton's physics. Look at this. The next thing, what is the function of synovial fluid? Reduced friction, okay? Reduced friction, right? Okay. So that's about synovial fluid. Third joint protective mechanism, guys, is our mechanoreceptors. Mechanoreceptors, guys. What are they sensing in the joint space? We talked about before as well. What are they sensing? Sensitive to stretch, right? They are sensitive to stretch, right? So basically we are talking about mechanoreceptors in ligaments, right? In the same joint, ligaments of that particular joint, right? Tendons, okay, and overlying skin. What do these do? Look at this, guys. The mechanoreceptors present at a particular joint, they supply this, they take sensory signals of stretch from these ligaments, tendons, and overlying skin. Let's say if I'm using elbow as an example, they take these sensory stretch signals all the way to our brain and then take it to the motor cortex and fire back, right, to our muscles, to the muscles required for me to move this elbow joint. Okay, so what does it do? They fire at various frequencies throughout the range of motion, right? throughout the range of motion. What does that do, guys? The effector muscles, right? The effector muscles, for example, the flexor. In this case, for this movement, I need my biceps to flex, right? These muscles, the effector muscles, they can assume the perfectly right tensive forces necessary to follow that range of motion. Okay, for example, if I want to move my hand rapidly like this, right, the tensive forces that my muscles should produce are higher, right? Okay, so while this is happening like this, while my hand is coming this way, right, these stretch receptors, they continuously communicate with your higher motor centers, and they send right signals, right impulses, right, to make sure that my arm is coming directly like this. If they weren't working, what will happen? My arm will go somewhere else, right? Arm will go somewhere else, right? So the range of motion is nicely controlled, right, and preventing things like dislocations. Okay, that's what these mechanoreceptors do. Okay, y'all can write down: effector muscles and tendons can assume the required tension, right? Effector muscles and tendons can assume the required tension on joint movements to follow the correct ROM, to follow the correct ROM. Okay, correct range of motion. Okay, right. Right. Then the next one. Let's go. Fourth one, right? The fourth one, guys, basically we are talking about all these structures that are bridging the joint, right? The muscle, the ligaments, the tendons, right? The tendons which are bridging the joint, right? What do they help with, guys? Especially muscles, you all know, usually they work in pairs. So they help with coordinated action, coordinated joint movements, right? Movements, coordinated joint movement, right? And then these ligaments and tendons, these supportive structures, what do? They help with the even distribution of force, right? Even distribution of force, right? Across the joint, right? So focal stress on one part of the joint, on a single part, there will be no very high stress in your joint when it's moving, right? That entire joint, nicely, the forces will be spread, right? So there is no specific damage to one part. Okay, right? Clear? Now, so these are the main joint protective mechanisms we want to know, guys, right? What I want you all to know: failure of any of these joint protective mechanisms, what will happen? It will increase joint vulnerability, and therefore pave the way to osteoarthritis, right? Osteoarthritis. Okay, don't worry, we'll look at how these things are failing in the pathophysiology, right? This is first, we learn the physiology now. What are the joint protective mechanisms? Right? Clear? Okay. Now we'll look at what things cause these joint protective mechanisms to fail. Basically, now we are going into the etiopathogenesis, guys. Etiopathogenesis. Right? We are going to talk about, firstly, what conditions predispose, right, to the failure of this joint protective mechanism. Basically, we are talking about what are the risk factors, guys. What are the risk factors? Now tell me, this osteoarthritis generally, is it an acute condition or a chronic progressive condition? What is it?
Chronic progressive.
It's a chronic progressive condition. So what do you think about these risk factors? Are these one-day acute risk factors, or are these chronic risk factors? Yeah? Mainly chronic risk factors. So let's have a look at them, right? First one, guys. First one is age, right? Age. This is the most potent risk factor, guys. This is the most potent risk factor. Especially you can say after the age of 50 to 55, right? The risk of osteoarthritis risk of osteoarthritis increases exponentially, right? Right. Having said that, osteoarthritis can occur at any age. Doesn't mean only after 50 to 55. No, but the risk increases. The risk increases. Right? Okay. How does this happen? Why does age cause this increased risk? Right? Look at this, guys. First thing, write it down first. Chondrocyte metabolic activity is reduced. Now, when I say chondrocyte metabolic activity, what do I mean? What comes to your mind?
There is no degeneration done.
Yeah, basically synthesis, right? When I say metabolic activity, I want you all to think synthesis. If I say catabolic activity of chondrocytes, we are talking about degeneration, right? Degeneration, right? Chondrocyte metabolic activity is reduced. Why does this happen, guys? Look at this. First thing, you all know, guys, at young age, now I know many of us here are above the age of what? Maybe 22. I don't think there is anyone younger than 22. When you all were younger, always running about the house, going here and there, very active. Now, especially those who are maybe close to my age, those who are maybe past 25, how difficult is it for you all to get out of the bed in the morning? How difficult to stand up sometimes, right? So this is, guys, at young age, our body level of activity is high. Okay, when our activity is high, guys, right, our joints, we have dynamic loading of our joints repetitively throughout the day. Dynamic loading of joints repetitively throughout the day when we are young, because we are doing a lot of things. We are doing sports, we are running, we are very active, right? So what happens, guys, when there is dynamic loading of joints, when your joints are always working, what do you think happens to the cartilaginous areas? They are always prone to a little bit of damage, right? So what happens in the young age, guys? This dynamic loading is always activity, right? Continuous activity. It helps stimulate our chondrocytes to increase metabolism, right? It helps stimulate new cartilage production by the chondrocytes, right? Okay, but what happens as we age, in older age, right? Okay, some of us here as well, right? What do we have? Backaches, konde kakkuma, here kakkuma, there kakkuma, everywhere pain. So what happens? Our activity is reduced, guys. Our rates of activity reduce. So what is happening? One thing, the dynamic loading of joints is reduced. So our chondrocytes aren't stimulated. Nothing is coming and telling the chondrocytes, hey, produce some extra cartilage. No one is coming and saying that, right? So that is one reason. The other thing, guys, even let's say you're a very active person, right? Even if you are very active, with age, especially in old ages, guys, after 50, after 55, even if you are very active, the chondrocyte responses to stimuli of dynamic loading is less, right? Chondrocyte responses, you can say, responses to stimuli of dynamic loading is less. What do I mean by this, guys? Let's imagine we have two athletes. Both are training for the 100-meter event, right? Both are training for the same competition on the same day. They are following the same training schedule, right? One is 25 years old. The other guy is 50 years old, right? Both are doing the same activities all throughout the day. However, the younger person, right, will have more response to stimuli in his cartilage for his chondrocytes. His chondrocytes are stimulated more to produce new cartilage compared to that older person. That's what I want you all to understand here, right? Okay, clear? Okay, right. Second thing, guys. So that is the first one. Second point, as we age, what happens, guys? Our muscles become weaker. Muscles become weaker, right? This is called, these are senile changes, guys. Age-related loss of muscle mass, right? Age-related loss of muscle mass. What is happening, guys? When muscle mass is reduced, joint stabilization is reduced. Joint stabilization, right? Joint stability reduces. Joint stability reduces. Okay, right? Then, what do you think about nervous stimulations? Do they increase with age or reduce with age? Huh? What happens? Nerve impulse transmissions? What happens? Yeah, reduces, right? Our sensory fibers, guys, especially our mechanoreceptor functions, right? Mechanoreceptor functions reduce. Mechanoreceptor functions reduce, right? The nerve inputs, they slow down with age, right? Therefore, what happens? What do you think about the range of motion? Our movements, guys, right, with age, right, they can follow abnormal ranges of motion, right, and that can also induce some damage, okay, following abnormal range of motion, right? Again, same thing, guys, you all can write ligaments as well. You all know with age, what happens to ligaments with age? What happens?
Weaken.
Yeah, they stretch with age, right? Ligaments stretch, they thin and they stretch, right? So again, what is happening? Joint stability reduced, right? Ligaments stretch with age. Okay, right? Clear. These are the things about age, guys, age related. Now, tell me this, age related osteoarthritis. Is it primary osteoarthritis or secondary osteoarthritis? What is it? Huh?
Secondary.
Is it secondary? We classify this under primary, guys. First thing, not all aged individuals will get osteoarthritis. So we cannot say age is a direct cause, right? We don't know why it's happening. So this one falls under this idiopathic or age related, right? These are usually classified together, right? So we put them under primary, right? There are various mechanisms going on. Few of them are these that we discussed here, these 4 that we discussed. Okay, these are primary, huh? Right. Next one, sex or gender. Sex or gender. Tell me this, huh? Which one is more prone to develop osteoarthritis? Who?
Females more.
Excellent. Females more than males, especially, guys, especially they have observed, especially after menopause, right? After menopause, the female to male ratio increases so much. Okay, after menopause. Why exactly this happens, we don't know, but they are suspecting there might be a role played by sex hormones, right? By sex hormones, right? We don't know the exact cause. Okay. Then, guys, third one, heritability and genetics. Heritability and genetics. This one is very important. This one is very interesting, right? Heritability and genetics. Look at this, guys. Heritability and genetics, there is a joint, we say there is a joint specific heritability, right? A joint specific heritability. What do we mean by that, right? What do I mean by that, guys? If you look at in the general community, let's say you are doing some research project about osteoarthritis, you collected a large sample of people with osteoarthritis. They have various types of osteoarthritis, right? In the community, if you look at hand and hip osteoarthritis in your community, right? Of the sample that you collected, more than 50% of them will have will have a inherited background. What does that mean? When you take their history, they will tell you, my mother had this, my father had this, my brother had this, right? Or maybe a little bit of an extended family, my uncle had this, right? So hand and hip osteoarthritis, more than 50% of the cases are like that. But if you compare that to knee osteoarthritis, guys, knee osteoarthritis, you will find only about 25% of the cases have a heritability, right? Have a heritability. Others are caused by obesity, which we will talk about next, right? In knee osteoarthritis, right? So that's why we say this is a joint specific heritability, joint specific heritability, right? Okay. Then the fourth one, guys, look at this. Fourth one, we call these loading factors. Loading factors, right? Loading factors. What are these loading factors, guys? Basically, how much of weight, right, we are putting on a joint, right? This is what we basically mean by loading factors. What I want you all to know, this risk factor, this loading factor, risk factor, right? This one mainly affects knee osteoarthritis than any other one, right? Than any other one. Look at this. First one, obesity. Obesity, right? Obesity. Look at this, guys. Okay. The knee. You all know, guys, every time you walk, right? Every time you walk, we have something called a single leg stance, right? Every time you all know, right? When you all are naturally walking, right? At a fraction of a time, one of your legs would be on the floor and your other leg would be in the air, right? This is what we call a single leg stance. In a normal person, guys, during single leg stance, right? During single leg stance in a normal person, there is a 3 to 6 times body weight being transmitted across the knee, right? Across the knee in a normal person, right? In an obese person, what happens, guys? In an obese person, right, by this 3 to 6 factor, right, we have to increase whatever their body weight is, and we to calculate how much is transferred across the knee, right? So what do I want to know? What do I want you all to know here? Greater the larger the BMI, obesity, BMI, yeah. Obesity means what, guys? What is the BMI? Greater than
20.
Greater than 30, right? Greater than 30 is obese, right? Greater than 30 is obese. The more farther away you go from 30 or above 30, what is happening? The greater the risk of osteoarthritis to your knee. Okay, that's what I want you all to understand here, right? So what is going to happen, guys? Cartilage wear and destruction. Cartilage wear and destruction is very high. Okay, right? So this is one of the things, right? This is a mechanical mechanism. The other one is, guys, the bio side of this. Now we said osteoarthritis is biomechanical, right? We look at the bio side of this. In an obese individual, guys, can you all tell me, what do you all think about the adipose tissue density? Is it high or low? Obese individuals. High, right? Adipose tissue density is high. Adipose tissue density is high. If adipose tissue density is high, guys, look at what is going to happen. Our adipose tissue, guys, it can produce something called adipokines. Adipokines. What are these adipokines? These are basically cytokines from the adipose tissue, right? So we call them adipokines, right? Cytokines from the adipose tissue. Now, look at this, guys. You all can draw it like this. Let's draw some adipose tissue here. Let's draw some adipose tissue here. Right, this is adipose tissue, and adipose tissue is releasing adipokines. Let's say something like this. These are cytokines released by adipose tissue, right? Adipokines. Look at this, guys. This adipokine release varies. What do I mean by varies? Look at this. You all can draw it. We'll draw someone like this, a very thin person. Then we can draw someone lean or normal, right? A normal person. And then you can draw, right, someone like that, a little bit obese, right? Right? So we have a lean person, right? This is our normal, right? And we have an obese person, right? And someone maybe who is on calorie restriction, right? We can say underweight, right? Underweight. Now, look at this, guys. What I want you all to know, these adipokines, guys, are both. There are two different types. Adipokines, there are pro-inflammatory adipokines, pro-inflammatory adipokines, and anti-inflammatory adipokines, right? Adipokines are of two types, pro-inflammatory adipokines and anti-inflammatory adipokines. What happens, guys, when adipose tissue density is very high, right? When adipose tissue density is very high, pro-inflammatory adipokine release is going to be high, right? The underlying mechanisms are very in-depth, guys, in molecular level. We don't need to talk about this. Just know, in obesity, right, when the BMI is very high, when the adipose tissue density is very high, the release of pro-inflammatory adipokines is much higher, right? As opposed to that, anti-inflammatory adipokines is going to be lower, right? Lower. What do you think in the underweight situation? What is happening? Anti-inflammatory adipokines are going to be much higher, guys, if you check, right? And their pro-inflammatory adipokines are lower. Then what is this lean? This is our normal BMI, guys. This is homeostasis. Homeostasis, right? This is the homeostasis in normal BMI, right? So there is going to be a proper balance there. But in obesity, what happens? Pro-inflammatory adipokines increase. If you're underweight, what happens? Anti-inflammatory adipokines increase. Now look at this, guys. When this pro-inflammatory adipokines increase in obesity, we are focusing on obesity, right? We don't need to talk about underweight persons, right? In obesity, when pro-inflammatory cytokines are high, what happens? These cytokines, guys, they have some chemotactic properties, and they can also induce other pro-inflammatory cytokines, right? Induce other pro-inflammatory cytokines, right? Various interleukin 1, interleukin 6, TNF, all of these things, right? Pro-inflammatory cytokines. And what can they do in the joints, guys? They can induce inflammation, right? Induce inflammation. If there is inflammation in your joints, what is going to happen? Again, this cartilage wear and destruction is going to increase. We'll see how this happens in the pathophysiology. These are going to increase. Okay. So obesity, guys, previously what they thought was it is only the mechanical increase in weight that is going to cause wear and tear of the joints. But now we know there is a biological mechanism related to adipose tissue as well. Okay, right? Okay. Next one, guys. So that is obesity, about the loading factors. The first one is obesity. The second one is the excessive joint use, guys. Excessive joint use. What do we mean by this, guys? It can be occupational, or it can be sports related, right? Sports related. Look at this, guys. Occupational, right? You will come across, especially when you go for your internships. A lot of farmers, guys, they have a very high tendency to develop hip osteoarthritis, right? Osteoarthritis of the hip because of the position they are in, right, throughout their working days, right? What about minors? Minors also, guys, they can have a lot of knee osteoarthritis, and the minors are the ones who are commonly coming with shoulder. Shoulder osteoarthritis is not very common, but in minors, yes, right? Okay. So those things, I mean, not very important. This sports, guys, sports related, right? Now tell me this. Okay, sports related, there are some risks that can help develop osteoarthritis. Because of this, should we tell everyone not to do sports? Right? No, right? That's obvious. No. Look at this, guys. we always in Western medicine, whatever the condition, right? Depends, unless the patient is bedbound or on surgery or something, right? Most of the time we suggest an exercise-filled lifestyle, right? There is no consistent association between exercise and osteoarthritis, guys, right? Over years of research, we haven't gathered enough evidence to say, right, these types of exercise can cause this osteoarthritis, like that. No. But however, what they have found out is elite athletes. Who are these elite athletes, guys? Guys who are competing at the Olympic level, right? Okay, international level. They are training day in and day out, right? That's all they do. That's all they do. For them, guys, depending on their type of sport, there can be, right, depending on the joints that they use the most, right, there can be some risks associated with osteoarthritis, right? So because of that, having said that, we shouldn't make the obvious mistakes. Now, if we completely stop exercise, what will happen to your muscle masses, your joint protective mechanisms? What will happen? Huh? Will you have dynamic loading to stimulate your chondrocytes to produce new cartilage? No. Your muscles will slowly start to atrophy and weaken, right? So joint protection, joint stability is going to be less. So therefore, we can never say stop all exercise. But having said that, let's say you get a patient with a knee osteoarthritis coming to you, right? Should you suggest him every day in the morning, wake up, run for 30 minutes as exercise? He's already having a knee osteoarthritis, let's say moderate knee osteoarthritis. No, right? We'll talk about in the treatment, right? We have to encourage exercise, but there are some things we need to consider. For example, if a patient is having a knee osteoarthritis, we tell him to increase upper body exercises compared to the lower body exercises, right? And then there is something called hydrotherapy, right? We'll talk about all of those later. Okay, so these two are under the excessive joint use. Basically, what happens, guys, over the long time, again, what do we have? Over the long time, cartilage wear and tear, cartilage wear and tear. Okay, cartilage wear and tear. Right. Then, so that is number 4. Number 5. Number 5. Trauma or previous injury. Trauma or previous injury. Trauma or previous injury. Write this down, guys. Any fractures, right? Any fractures through the articular surfaces, or involving the articular surfaces of a joint, right? These can pave a way to osteoarthritis, right? Okay, guys, tell me this. Okay, let's say we have, okay, let me draw something like this. Let's say we have a bone here, right? And let's say this is the cartilage. There was some, let's say this one guy met with a motor vehicle accident, and somewhere from here, a big fracture, right? Let's say a piece of bone was removed, right? Whatever, right? What do you think about the healing nature, right, of bone as opposed to cartilage? Think about the histology that we talked about.
Lower than.
Sorry?
Cartilage regrowth is slow.
Excellent. Why? Why?
Avascular.
Avascular in nature. Avascular in nature. This is the disadvantage of the cartilage being avascular. What is the advantage of the cartilage being avascular? What is the advantage?
No hemorrhage into the joint.
Hemorrhage.
Okay. More than that, guys. Okay, that is also correct in a way, right? That is also correct in a way. But more than that, if a cartilaginous structure has a good supply, it will get all the nutrients essentially, and it will ossify, right? It will become bone. It will become bone. Why cartilage can remain as cartilage, right, is because they do not have a blood supply. Okay, they do not have a blood supply. Now, in the pathophysiology, we will see this. There is something called osteophyte formation, right? We will see those cartilages are going to get a blood supply. right? And then they ossify. They immediately ossify. We'll see what is going to happen. Okay, right. Then guys, so that is one of the things, fractures through any of the articular surfaces. That is one reason. The other one is, guys, previous surgery. Okay, previous surgery. For example, have you all heard something called meniscectomy? Meniscectomy, not commonly done, guys. This is done, you all know, in the knee, there is the tibial cartilage. We call this the menisci, right? There are two menisci, right? This is usually done, guys, if the damage to the meniscus is non-repairable, right? If it is non-repairable, then we remove the meniscus, right? There is replacement as well, right? Now replacement is practiced more, but those days they used to completely remove it, right? So that also can predispose to osteoarthritis. Okay, right? Then the last one, guys, other diseases, right? This one, nothing to discuss much, right? Other diseases, you all can just write down, rheumatoid arthritis, right? Gout, spondyloarthropathies, all of these, don't worry. Students in the program, these chapters are coming up, right? Arthropathies, okay? Paget's disease, whatever, okay? Paget's disease. These ones are going to be discussed, right? Then there's another one, guys, avascular necrosis. This is, I'm talking about avascular necrosis in adults. What drug is related with this? Very commonly used. Yeah, excellent, right? Excellent. Corticosteroid use. Why? Why do corticosteroids do this? This one, guys, actually the proper reason is not known, but what they're hypothesizing is corticosteroids, they can increase your blood lipid levels, right? Your blood lipid levels. So there can be fat emboli, there can be atherosclerotic changes, right? Eventually they can cut down blood supply to the bone, right? That is going to cause avascular necrosis. Now, since there are juniors here, don't get scared. What is avascular? Avascular means there is no vessel. The blood supply has been cut down. Necrosis means what? When a structure doesn't get blood, it's going to die. Necrosis, right? Avascular necrosis, right? Especially due to corticosteroid use, especially like high dose methylprednisolone and all of this, right? Right. Next one, guys, some endocrine conditions. Students who came for the last module, right? Tell me, what are two endocrine conditions that can maybe cause some joint abnormalities and give rise to osteoarthritis?
Graves' disease.
Okay, how?
Weight gain.
Okay, no. Can you all tell me some direct damages to the bone? Some direct methods.
Cortisol.
Cushing's.
Now, at the beginning, we already mentioned one, right?
Diabetes.
Yeah, diabetic, Charcot's neuroarthropathy, right? Charcot's neuroarthropathy. Then anyone who came to my classes, try and remember and tell me some direct disease of the bone that we talked about, relating to the bones. Acromegaly, excellent. Do you all remember? So you all can put endocrine diseases. One is diabetes mellitus, the Charcot's neuroarthropathy, right? Charcot's neuroarthropathy. Second one, guys, acromegaly, right? Acromegaly, what did we talk about? There is going to be excessive bone growth, right? It's basically excessive bone growth. Initially, up until the epiphyseal growth plate closes, the bones will increase in length. After that, what happens? Bones start widening. Remember their hands? We said spade-like hands. I hope you all remember all of those. Go through those again. Right, so because of that, those are also, guys, they can give rise to joint abnormalities, and therefore articular surfaces can undergo increased friction and therefore result in osteoarthritis. Okay, right. Then, guys, there are some congenital things we need to talk about. Congenital, right? These ones mainly you will come across in pediatrics and pediatric surgery, right? Right. There is one, guys, slipped femoral epiphysis. slipped femoral epiphysis. What is this slipped femoral epiphysis? This one, guys, mainly in teenagers, right? In teenagers, what happens? The femoral head, guys, if you look at the structure of the femoral acetabular joint, right? It looks something like this, right? Draw something like this, right? Something like that. And what is happening? The head of the humerus is usually, femur, head of the femur is usually there. And maybe structure like that. It's usually like this, right? This is the joint, usually. What happens? And here you have the growth plate, right? Look at this. What happens is, guys, this femoral head, it slips downwards and backwards. It slips like this. It slips like this. So what is it? What is going to happen? It's going to separate from this growth plate, guys. It's going to separate from the growth plate. What it is going to look like this, don't worry, you all will talk about these in your surgical chapters and your pediatric chapters, right? Right, it will be something like this. This will come a little downwards. Yeah, something like this. This will be like this, guys. This will separate. This will separate. Okay, from this structure. Something like that. Yeah. Okay, slipped femoral epiphysis, right? Okay. Then another one, another important one. Tell me this, senior students, let's say a 7-year-old boy, right, is brought into the hospital with a limp. He has normal body weight, right, not obese, right, and he's doesn't have fever or anything. What is your likely diagnosis?
Perthes.
Yes, correct. Good. Leg calf, CALV, calf Perthes disease. Perthes disease. Don't worry, juniors, don't get scared of all of this, right? These are not for this chapter, guys, but under the other diseases that can give rise to osteoarthritis, we need to just mention them, right? You will learn these in depth in other modules, right? Okay. Now, these conditions, guys, we call them congenital, but do we mean congenital osteoarthritis? No, these are congenital conditions, guys, that can give rise to early onset osteoarthritis. Early onset osteoarthritis. That means, right, maybe somewhere in their teenage ages, or maybe young adulthood, maybe 20, 23, 24, right? At these ages, they get osteoarthritis due to these congenital issues that they had. Okay, right? Right. Then the next one is, guys, anatomical malalignments. Anatomical malalignments. Right? What are these anatomical malalignments? I'm going to draw them. You guys can name them to me. Right? Right? This is number one. Right, something like that. This is number two. What is number one? What is number two? This is the knee, this is the leg. You all can identify, right? Right? That's the leg. Okay. What is one? What is the deformity?
Board legs.
Yeah.
Oxal. Yeah.
Okay. Wait. I'm not sure. I think I heard someone say the correct answer. Guys, okay, don't okay, look at this. Right? Correct. Board legs, right? If you want to scare the patient, if you want to show that you know some extra terms, what do you say? You have genu varus. Okay, okay, okay. Look at this. Genu varum, genu varum, and genu valgum. Right? Okay, varus and valgus deformities, right? Varus and valgus. You all know, guys, how to remember this? You all must have studied when you all are in your smaller grades. Gum sticks your knees. That's what they say. Gum sticks your knees. So in this case, the knee joints are very close together. In this case, in the first case, in varum, right, the knees are away from each other, right? Here's the important thing I want you all to know here, guys. If I'll just draw the rough bone structure. Look at this, right? It'll look something like this. Then for the valgum, if I draw the bone structure, it'll look something like this. Right? Now, look at this. If you look at the varum and the valgum, where the bones are undergoing the most stress, right? Where the bones are undergoing the most stress. In the varus deformity, is it the medial side or the lateral side that is undergoing the most stress? In the joint, the medial side. The medial side is undergoing the most stress in the varus deformity. What about the valgus deformity? It is the lateral aspects. The lateral aspects, right? So what is happening is, guys, these anatomical malalignments, right? They affect the part of the malaligned joint that is under the most stress. So if osteoarthritis were to develop in this varus deformity patient, it will start off here. It will start off at the medial aspect, right? Okay. In the valgus deformity patient, if osteoarthritis was to start, it will start off at the lateral aspect, of the knee joint. Okay, of the knee joint. Okay, right. So these are the main things that I want you all to know. These are the main secondary causes, rather. All of these other diseases, guys, when they give rise to osteoarthritis, we call it a secondary osteoarthritis due to some other disease condition. Just note here, guys. Tell me this. This one I have to say it here because it is coming for your true or false questions, guys. Tell me, true or false? Osteoporosis increases the risk of osteoarthritis. True or false? Osteoporosis increases the risk of osteoarthritis. True or false? True. Any other answers?
False.
False. Okay, false. Right. Students who said false. Why did you say false? Why?
In osteoporosis, the density reduces.
Right. Okay, good.
And
good,
that
good.
will not put pressure on the joints.
Right, excellent. Look at this, guys. Osteoporosis, if you logically think, right? Now, students who said true, good, you all are logically thinking, right? If you logically think, what happens in osteoporosis, we think, okay, the bone becomes weaker. So maybe it is more prone to damage. So when there is mechanical stress, okay, maybe the risk of osteoarthritis is high. That's what we logically think. Actually, guys, what happens is the risk of osteoarthritis is low. The exact reason, not properly known, but what we know up to now is this. When we have osteoporosis, right? You all know, guys, there is something called bone mineral density. Bone mineral density, right? Bone mineral density. What is bone mineral density? This is basically a measure of how much of minerals, basically your calcium, phosphate, and these major minerals is present in your bone. When we have osteoporosis, bone mineral density reduces, guys. Right? Bone mineral density reduces, right? Therefore, what they say is, right, the calcified structures in your bones is less. So your bone is more amenable to compressive forces, right? They believe that when the bone mineral, basically imagine this, guys, bone mineral density, when it is reduced, the bone becomes less of a rigid structure, right? The bone becomes less of a rigid structure. So imagine the bone is a little bit more elastic now, right? Imagine like that. It's not exactly what happens, but imagine it like that. So what do you think happens to the shock absorption capability? If a bone is a little bit more elastic than usual, shock absorption is much better, right? Shock absorption capability is better. So that's what we know up to now, guys, right? There are some other theories that are hypothesized as well, right? But so shock absorption better, Therefore, they say risk of osteoarthritis is lower. We have to know this, right? Exact mechanisms not known, right? But this is what we know up to now. Osteoporosis means what, guys? Basically, porous bone, right? Weak and brittle, porous bone, right? This is coming, we have it as the one of the upcoming chapters. I already discuss osteoporosis in depth, right? Just know, true or false, osteoporosis reduces the risk of osteoarthritis. Okay, that's true, right? Okay, guys. Now we are done with the 80% of the content for the day, right? Now we only need to discuss the exact pathophysiological mechanism. So we will take a 15-minute break and come back and discuss the pathophysiology and end the class for today. Okay, 15-minute break. Okay. Right. Is everyone back? Yeah. Right. Okay, guys. So now, let me share the screen. Let's switch to the pathophysiology. Yeah. Okay. Give me a second, guys. Right. Guys, so if possible, keep your cameras on, so I can see at least when you all are done writing and all. It's a little bit difficult for me to judge if you all are keeping up with the lesson. If you all have confused faces, like what the hell is going on? Right? Okay. Right. Now we are going to talk about the pathophysiology, right? The first thing, guys, before we dive into the pathophysiology, I want to tell you all something. This is not a step-by-step process, right? Okay, we will see this evident towards the end of the pathophysiology as well, but just keep it in your mind that any of the things we are going to discuss now, right, can be seen in early osteoarthritis, can be seen in moderate osteoarthritis, and can also be seen in late. We cannot say these features will only be seen in late. It's difficult to say, but the severity of the conditions can vary, right? So we'll see what we are talking about. Okay, so we'll start off just drawing our normal bone, guys, right? This is a normal, let's say a healthy one, right? And guys, take a fully new A4 page, okay, for A4 or whatever book you all are writing down on. Take a new page, and here we have the articular cartilages, right? And you all know, surrounded by the synovium, right? Okay, and then we also have the joint capsule, right, surrounding the entire thing, right? And okay, don't forget, we can have some bursa here, right? Bursa somewhere there, right? Right. Look at this, guys. Now this is our normal joint. So what can happen, right? the risk factors that we talked about can be affecting this normal joint, right? Risk factors, right? We cannot isolate and say which one exactly, but a multitude of risk factors, especially since this is a chronic disease, since it's a chronic progressive disease, multitude of long lasting risk factors can come into play here. Give me a second, guys. Let me, right, there we go. Can see more of you all now. More black screens, but right, okay. Look at this, right. Now, due to these risk factors, guys, due to these initial risk factors, what is one of the earliest things that can happen, guys? Cartilage wear and tear. Now, we've repeated this throughout today's class. What do we mean by this cartilage wear and tear, guys? Right, this cartilage will become a little bit irregular, right? Irregularly shaped. Now, previously it was a nice glass, smooth porcelain-like shape, right? Now it's going to become a little bit irregular, right? Something like this, right? You all can draw something like this, a little bit of an irregularly shaped cartilage, right? So what is happening? Because of, okay, maybe don't draw like outgrowths. It will still be the same cartilaginous shape, no outgrowths as such, but a little bit irregular, right? This is, guys, our basic cartilage wear, right? Cartilage wear. Okay. Right? What happens because of this? Let's see what happens. Now the risk factors are acting. There is generalized cartilage wear in the synovial joint. Let's see what is happening, right? Right, draw an arrow to somewhere there. Guys, draw this diagram in the same way that we are drawing, because all these arrows will come all over the place. If not, and your diagram will look a bit messy. So I've tried to make it as clean as possible, right? One of the first things, guys, now tell me, in our body, is some structure is being degenerated, right? Or is some structure is undergoing wear? What is our body's natural propensity? To try and produce that structure again, right? To try and rebuild that structure. So what is happening here, guys? When there is generalized cartilage wear, what happens is our chondrocytes start hyperproliferating, right? Chondrocyte hyperproliferation, right? Chondrocyte hyperproliferation, right? What is going to happen, guys? Now, if you all remember the functions of chondrocytes, you all know chondrocyte, it maintain a dynamic equilibrium between cartilage production and cartilage degradation, right? Initially, guys, what is happening is, from some underlying mechanisms, initially the metabolic activity increases. Initially, metabolic activity increases. That means what? Extracellular matrix production increases. Extracellular matrix production increases, right? In an attempt to heal this wearing of cartilage, right? The chondrocytes will start producing more and more new cartilage. Now tell me this, okay, more and more new cartilage being produced, but does it mean that these chronic risk factors have been resolved, have been removed? These risk factors, just because chondrocytes hyperproliferated and produced new cartilage, does it mean that the risk factors were removed? No. Risk factors are still there. So what is happening, guys? With time, okay, with time, what happens to these chondrocytes? We call it chondrocyte exhaustion, right? Because they have to continuously keep producing and producing and producing, right? Chondrocyte exhaustion. So their ability to produce ECM goes down. ECM production goes down. Now, this is like a seesaw, right? If the production side goes down, which side goes up? The degradation side obviously increases. So what is happening here? ECM degradation starts to increase. We'll see how this happens, right? how this happens, before we talk about how this happens, guys, just try to keep a small space right at the corner of your page, at the right corner of your page, because there is going to be some arrows coming at the right corner. Sorry, I forgot to mention it at the start. Try to keep a small space. It's okay, a little space is enough. We have just about 2 lines coming up. It's okay, right? Just keep a small space at the right corner. Right. Okay. So ECM degradation increases, right? What do we mean by the moment you hear ECM degradation? Tell me what things are actually getting degraded. What things? What are we discussed the histology of extracellular matrix? What is that?
Collagen, elastins,
Right.
proteoglycans.
Proteoglycans. In the proteoglycans also, what is the major structure there within the proteoglycan?
Hyaluronic acid.
Okay, hyaluronic acid, and what is the other part? The aggrecan, right? That is the negatively charged particle, right? Okay. When you hear ECM degradation, the 2 most important things I want you to know: type 2 collagen reduces, type 2 collagen drops, and aggrecan drops. Aggrecan drops, right? These 2 are the most important 2, right? That I want. Other things also reduce, guys. The elastins, all of those are going to reduce, right? But these 2 are the most important ones, right? Now, when these 2, now you all know type 2 collagen is in charge of what? In the normal physiology, what does type 2 collagen give for our cartilage? What does type 2 collagen do in the cartilage?
Oh, tensile strength.
Okay, right? Tensile strength reduces. Tensile strength reduces. What does aggrecan do? Compressive stiffness. Compressive stiffness. Don't forget these, huh? So compressive stiffness, right? Compressive stiffness reduces, right? Overall, guys, what do you think is happening to our cartilage? It is becoming weaker, correct? Cartilage is becoming weaker, right? Overall, you can say, put something like that, right? Cartilage, you can say resistance. Cartilage resistance reduces. Cartilage resistance reduces. Okay. Then what happens? Cartilage wears down more. What happens when cartilage wear happens? When cartilage wear happens, again, what happens? Chondrocytes hyperproliferate, right? Now, can you see, guys? This is like a cycle. This is sort of like a vicious cycle, right? Okay, chondrocytes getting, the cartilage is getting weared off. Chondrocytes hyperproliferate. They try to produce more ECM, right? Eventually, they get exhausted, and then collagen and aggrecan reduces. Again, further weakening of the cartilage. Again, the lower layers of chondrocytes will hyperproliferate. So this is continuing like a cycle, guys. It continues like a cycle. This is why initially in the clinical side, we will see, guys, when we come to the clinical diagnostics, right? Initially, in a patient developing osteoarthritis, especially in early stages, you all know the disease progression can vary, guys. Some people 5-10 years after they will start showing, right? So during these early years, patients will have occasional joint pains, right? They will have a joint pain somewhere, and then for a few months, no problem. Again, a joint pain somewhere for a few months, no problem, right? Usually when you're taking history, guys, from a, let's say, mild to moderate case of arthritis, if you ask the history from a patient, he will say, those days, doctor, I had some pain every now and then. I didn't care about it, right? Why is that? It's because of this. So whenever chondrocytes are hyperproliferating and ECM production increases, right, the cartilage gains a little bit of strength. So the friction reduces a little. Okay, then, okay, no pain. And then what is happening? Again, chondrocytes get exhausted, right? They break down, collagen is reduced, aggrecan is reduced, again, get a little bit weaker. Again, friction increases a little, again, a little bit of pain. Intermittent pain, right? In very early stages of osteoarthritis. This is how it happens, okay? We'll talk about this in the clinical, but in the pathophysiology, important to understand, okay? Intermittent pain, right? Okay, clear. This is one of the first main things to talk about. Understood? Give me a thumbs up. Let me see the 5 faces that are showing their faces. Thank you. Right? Oh, 6. Okay, we have 6. Right? Right. Okay. Let's go to the next one. Right? Now put another arrow in this way, guys. This direction. Right? We'll go there. Right? Now what is happening, guys? Over several number of years, as we have seen, there will be intermittent pain. There will be a gradual thinning of the cartilage. So we have gradual, you can say gradual loss of hyaline cartilage. Hyaline cartilage, right? This is what we have. So whenever hyaline cartilage is being reduced, guys, in our synovial joint, what do we know? Friction increases. Friction increases, right? Friction increases. Okay, friction increases, right? Now look at this. This is a little bit important to understand. Look at this, guys. It's like this, right? This is, let's say, okay, let's say this is our joint, right? These places, guys, now we know cartilage has become a little bit thinner. Cartilage has become a little bit thinner. Wherever this thinner cartilage is rubbing against each other, guys. You all know cartilage during joint movements, they can rub against each other. The thinner the cartilage is, when they are rubbing against each other, right? Those places can undergo severe stress, guys. Let's say here and here, they rub together. Let's say somewhere here and here, right? Maybe somewhere here and here, right? These focal areas, guys, these focal areas that rub against each other, especially when the cartilage is thin, these areas, there is something happening, guys. There is focal chondrocyte apoptosis due to the increased friction in these areas, right? It is not a generalized thing, guys. Not the entire cartilage is not affected yet, right? Focal areas. There are focal chondrocyte apoptosis that is going to happen. The chondrocytes that are there are going to die, right? Chondrocytes in those focal regions are going to die, right? Okay. All right. So there is further thinning of those. Now those areas are going to be completely devoid of chondrocytes. Chondrocytes are dying in those areas. Focal, right? Focal chondrocyte apoptosis. Therefore, guys, those areas become very weak. Let's draw the next diagram, right? Those areas, let's say it was something like this, the same bone, huh? Same bone. Those areas, guys, become very weak, right? And there is sort of like an erosive change towards the bone. It will look something like this, guys. After a while, let's say this was the initial cartilage, right? Let's say these areas were touching each other, right? Now what is going to happen? It's going to appear, don't draw, huh? After I tell you all, you all can draw. It's going to appear something like this. Let's say here, somewhere here, somewhere here, here, right? It's going to start appearing, guys, like this. There is erosive changes towards the bone, like that, right? They're going to erode away towards the bone, right? Something like this. Okay, right? These are called, guys, now you can draw. These are called fissures. These are called fissures, right? Basically, from those focal chondrocyte apoptosis region, cartilage is being destroyed in those areas because there are no chondrocytes, right? So those cartilage pieces actually, guys, if you look at now, you all know this is surrounded by the synovium and the synovial fluid is here. Those cartilage pieces will start floating into the synovium, right? Those broken down cartilage pieces, right? They will start falling into the synovium. We'll look at that as well. These areas here, guys, these damages, these are called fissuring or fibrillations of cartilage. Fissuring or fibrillations, both mean the same thing. Huh? Some books say fissuring, some books say fibrillation, both means the same thing, right? Okay, fissuring or fibrillation. Now, when there are fissurings or fibrillations, what do you think about the amount of friction at this joint, at the articular surface? Huh? Look at this, guys. Usually cartilage is supposed to be something like this, nice and smooth. Now it literally looks like teeth. right? It literally looks like teeth. That's what it looks like, right? So friction is now going to be very, very high, right? Friction at this articular region is going to be very high, right? Okay, right? Clear, right? Fissuring and fibrillation, friction going to be very, very high. Now, due to this fissuring and fibrillation, we'll see what is happening, right? There are actually, guys, two things that are going to happen, right? Draw it like that. Let's see what is happening, right? Here, guys, you all can draw. Let's draw it in a box. Let's take, right, zoomed in view of maybe somewhere, some area like this, right? Let's take a zoomed in view of that, right? And let's draw it here. So here, let's say we have the articular bone, the two articular bones like that, right? And let's say the synovium is somewhere here, something like this, right? It's just a zoomed in view. And now the cartilage looks like what? There are fissuring, right? Something like this. The cartilage looks something like this, like teeth, like some incisors, right? This is what the cartilage now looks like. Okay. Right. Now, what do we know, guys? Those particles of cartilage are going to fall off into the synovial fluid, right? Particles of cartilage are going to fall off into the synovial fluid. If we zoom and look at these particles, they look like this, guys. They look, if we zoom and look, they look like this. What do these look like? I don't know if I'm drawing it properly. What do these look like? Okay, if I draw it something like this.
Rats.
Yeah, like a rat, right? Okay, perfect. So you all can identify my drawing. These are called joint mice. Okay, these are called joint mice. Okay, they don't actually look like rats, guys, but that is what it's called. So we'll draw it like that. It's easier to identify them, right? These are called joint mice. These are basically flaked off cartilage fragments, right? Fragments of the cartilage that have been flaked off. They are called joint mice. Joint mice. Okay, mice as in plural of mouse. Okay, joint mice. So there is going to be a lot of joint mice now in this synovial fluid. Synovial fluid, right? Now, if you remember the cellular structure of the synovium that we talked about, synovium is made up of, the intimal layer of the synovium is made up of how many types of cells?
Two.
Two different types. What are the two types?
Type A, type B.
Type A, type B, what?
Synovial.
Yeah, that's the hard, right? Synoviocytes. Okay, right, good. Look at this. So let's draw some, these type A ones, right? Type A ones, then and some type B ones as well, here and there, right? Something like this. Type B, I will draw it like a letter B so that it's easy, right? Okay. Now, which one is responsible to produce synovial fluid? Type A or type B? Type B. Type B is responsible to produce synovial fluid. Type A, guys, these dark purple fellows that I have drawn. Type A, what did we say? They are derived from monocyte. They have a monocytic derivation, right? So what happens? They have lymphocytic-like, phagocytic-like functions. What they can do is, guys, when these joint mice are here, right, they will take some of these joint mice up. They will engulf them, right? It's like a phagocytic procedure, something like that, right? They will take up this in an attempt to clear the, because they always want to keep the synovial fluid clear of any debris, right? So these type B synoviocytes, what they do is they engulf these joint mice, right? They engulf these joint mice. Okay, right? What happens, guys? They engulf the joint mice, and then there are some immune mediated reactions that are going to happen. We don't need to talk about all of them. What are they going to do? They are going to release, right, some chemotactic agents. Some chemotactic agents will be released. Now, released into where? You all know the synovium. Is it vascular or avascular?
Vascular.
Vascular. Did someone say avascular? Synovium is vascular. Huh? Synovium is vascular. So there are nice blood vessels, guys, flowing through this region, right? So no problem. They will take up all of these, right? I'll draw some vasculature here, right? They will take up these chemotactic agents. What do? They call upon immune cells, guys, lymphocytes, right? Macrophages. All these cells will be chemotactically now attracted into the synovium, Now, when immune mediated cells are infiltrating spaces like this, what do we generally call it? There is inflammatory changes that are, yes, because these cells, guys, now when they're brought on, when they're called to this area, right, what do? They release pro-inflammatory cytokines. Right? Pro-inflammatory cytokines. So what is going to happen, right? This area, guys, the synovium is going to get inflamed. Right? Synovial inflammation is called what?
Synovitis.
Excellent. Right? This is inflammation. Right? We call this synovitis. Right? Synovitis. Okay. Synovitis. Okay. Now, here's the important thing, guys, I want you all to know. Because of this synovitis, right? The synovitis is a bit of a problem. Let's see, right? With time, if this synovitis continues, usually it does continue. Why? Because these risk factors cannot be easily removed, right? These are very chronic risk factors. So what is going to happen, guys, if we look at our bone structure? We look at this. Let me draw it again. Something like that, right? Now, if we draw the synovium, we are going to see the synovium inflamed, right? Synovium inflamed like this, right? Synovium is inflamed. What is going to happen, guys? First thing, with this inflammatory infiltration, right? These capillary permeabilities and all of these increase. What is happening, guys, to this joint? The fluid inside this joint space will increase, right? Fluid inside the joint space increase. We call this, guys, joint effusions, right? Joint effusions. Inflammatory material coming, inflammatory infiltration into the joint space, right? Then, guys, now if you all remember, some adjacent structures, you all know inflammation, it can spread from one tissue to another, right? Some adjacent structures, remember we drew a structure here. What was this? This was the bursa. If the inflammation spreads to these bursa also, what is happening? What do we call it? Bursitis. Yes, bursitis, right? Then you all know, if there is a muscle somewhere here, let's say a muscle somewhere here, right? And that muscle's tendon, let's say it attaches to this bone. Where a muscle attaches to the where a tendon attaches to the bone, guys, right? Here also there can be some inflammation. That inflammation can spread there also. What is that called? Enthesitis. Have you all heard? Enthesitis, right? Enthesitis, right? Bursitis, enthesitis, joint effusions, right? All of these can happen, right? All of these can happen, right? Okay. Right. Now, what's the next thing, guys? This inflammation, right? Let's say your immune system managed to somehow control it a little bit, right? And it managed to heal a little bit of this inflammation. What happens is, guys, on healing, there is even more problems occurring. When this inflammation, if it is made to heal, right, it will heal, right? But it will heal with fibrosis, guys, right? It will heal with fibrosis. So this nice, previously nice structure of the synovium now will start looking something like this, very disorganized, right? Because it's fibrous, right? Okay, this is, guys, this is called periarticular fibrosis. Periarticular fibrosis, right? Now for this fibrosis, guys, even the joint capsule can be involved. Okay, all these joint related structures can undergo fibrosis on healing, right? So what do you think? Will movement now, if this fibrosis happens, what do you think? Will movement of the joint be easy? Huh?
No.
No, right? Movement becomes very difficult. Movement becomes very difficult. At the same time, when there is fibrosis of the synovium, right? What do you think of the cellular function? For example, if you take type B cells, what do you think of their synovial fluid production function?
Decrease.
Yeah, synovial fluid will decrease, guys. Synovial fluid. Now, remember, in the joint effusion, right? We are saying there is a lot of fluid inside the synovium, correct? This is mainly, guys, there is some synovial fluid as well, but this is mainly your inflammatory exudation, right? Now, what is happening with the periarticular fibrosis, our synovial fluid will also reduce a little bit, right? Synovial fluid reduces. What is happening to friction? Sorry, reduces. What is happening to friction? Increases. Friction further increases, right? Friction further increases. Okay, right? Clear, right? I see you all writing. Okay. Right? Okay. Now look at this, guys. Let's go to the next one. We said there are two effects now here from the increase from the fibrillations and fissuring. Same thing. There are two effects, we said. So this is one of the effects, the synovitis, inflammation of the synovia, right? And its related consequence. The other thing is, guys, look at this. Now, when there is fissuring and fibrillation, what happens? The cartilage becomes so much weak, right? So during articulation, there is going to be very heavy friction, right? Eventually, guys, what is happening, right? The cartilage gets degraded so much that the joint space, this space between the joint, starts narrowing, right? Joint space narrowing, right? As the cartilage degrades, as the cartilage becomes weak and weaker. Eventually, guys, right? We might be able to see in some cases, in some severe cases, we see something like this, guys. Look at this. The bones are touching each other, almost no cartilage. Here and there, you will see some lines of cartilage, but that's it, right? This is, guys, we call this, we can see this in radiography, right? Tomorrow we will be looking at the x-rays, right? This is called bone on bone appearance, right? Bone on bone appearance, joint space narrowing, and then later it will progress to this bone on bone appearance. Now, tell me this, if it is bone on bone, can you imagine the amount of friction, right? Especially if it is in a weight bearing joint like your knee, imagine the amount of friction, right? There is severe friction in these areas, guys, severe friction, right? Very serious friction, right? This, as the bones are knocking together and articulating without any cartilage now, right? Without any cartilage, the surfaces of the bones are rubbing against each other. What happens, guys? There is a process we call this bone hibernation. Bone hibernation, right? Basically, imagine you're taking two stones and you're rubbing them together, guys. What happens? The surfaces become a little bit smooth, right? Of those two stones, right? Same thing here. These bones, guys, now what happens? This hibernation process, it appears like polished ivory like appearance, right? The surfaces of the bone, they look like polished ivory, right? Polished ivory. Okay. Right? Clear. And you all know, guys, this is what bone is meeting here now. Which types of, now in the structure of the bone, in the very first, at the start of the class, what bone is meeting here? Epiphyseal bone, metaphyseal bone, diaphyseal bone, which one? Or anything else?
Subcortical.
Yes, subcortical bone. I didn't give you all the option. It's okay. Subcortical bone, right? Subcortical bone is the two that are rubbing against each other now. Okay. When subcortical bone is rubbing against each other, guys, there can be also heard some crepitations. Crepitations. Basically, as the patient moves his joint, guys, you can hear some sounds, right? Tuck, 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 tuck. You can hear some sounds, not like that, but right, some very characteristic sounds. You all know lung crepitations, right? You all know lung crepitations on auscultation, right? Something similar to that. Something similar to that, right? Okay. Right? Okay. Now, look at this, guys. When the bones are rubbing against each other, anything else that can happen? Anything else?
Wear and tear of the bone.
Okay. Wear and tear of the bone, yes. Anything else? If you take your two hands, rub them strongly together, it will become a little bit red, it will become a little bit hot. Inflammation, right? Same thing. Inflammation also can happen here, right? Because of this bone on bone scenario, right? There is going to be inflammation here as well, right? Inflammation here as well, right? Okay. Wherever there is inflammation, guys, remember there can be pain along with the cardinal signs. So one of them is pain. Wherever inflammation is there, pain can be there, right? Now look at this, guys. Here we have an inflammation, right? Mainly of the synovium, right? Here we have another inflammation here, mainly of subcortical bone, right? We'll look at that in a bit. Now, look at this, guys. Let's now we will go a little bit here. We'll take this down, right? This one, right? Because of this bone on bone appearance, because of this hibernation, what can happen? Look at this, guys. What can happen is, look at this. Let me draw like this. Now what is happening? Bone is on bone, right? Bone is on bone. Here, guys, in the subcortical bone, what are the main two types of cells in bone tissue, guys? What are the main two types? Yes, osteoclast and osteoblast, right? Whenever bone is undergoing an erosive process, a damage destruction process, which one should be activated? Which one should be stimulated? Osteoblasts must be stimulated in order to produce more bone, right? In order to produce more bone and try to cure that, to heal that. That is exactly what happens here. As the subcortical bones rub against each other, right? And there is some friction, there is some degradation of the bone. What is happening, guys? This osteoblasts here, osteoblast cells in the subcortical regions, right? Subchondral regions, subcortical regions, right? Right? Subchondral regions. What is happening, guys? These osteoblasts get stimulated. Osteoblasts get stimulated, right? Osteoblasts get stimulated. Now, look at this, guys. Osteoblasts of the subchondral region, just under the cartilage, right? Osteoblasts of the subchondral region get stimulated. But let's say they start producing new bone. Let's say they start producing new bone, right? Is there enough space in the joint for the bone to grow? Is there now? There is no joint space. There is joint space narrowing, right? The bones are touching each other. So what is happening, guys, in this area, right? What is going to happen? Let's say these two are still like that. This subchondral region, guys, it starts thickening as osteoblast activity increases, right? Subchondral bone gets very much thicker, right? Subchondral bone thickening, right? Subchondral bone thickening. You can write it down. Subchondral bone thickening, right? This is what we call, guys, subchondral sclerosis. Subchondral sclerosis. In our body, if there is any structure, any tissue that is getting thickened, the word we use is sclerosis, right? So subchondral bone is getting thickened, so we call it subchondral sclerosis, right? Subchondral sclerosis. Okay, right? Okay. Right. Clear? Right. Then another one, guys. Another thing that is happening here. Look at this. Again, due to this bone on bone, huh? Again, due to this bone on bone, what happens? Right? Look at this. There is hibernation and increased friction and all of those going on. Eventually, what will happen, guys? Right? Okay, let me draw them. Touching almost. Right? Something like that. What will happen, guys? Right? Previously we saw when the focal areas, there were focal apoptosis of chondrocytes. Here, guys, now what is going to happen as these bones are touching each other, right? There is going to be, right? We call these guys subchondral micro cracks, right? These are not classified as fractures, guys. We just say subchondral micro damage. These are micro cracks, huh? These are not fractures, huh? It's just like the fissuring of the cartilage, but now it's in the bone. It's in the bone, right? Now it's in the bone, right? These are what we call, write this down as subchondral micro cracks or micro damage, right? Okay. And if the disease is advanced, guys, you all can write it in brackets. In advanced cases of osteoarthritis, you can even see osteonecrosis in these areas, right? Osteonecrosis also can be seen in advanced cases, right? Right? What is going to happen here, guys? Now you all know surrounding this joint is our synovium, and in this within the synovium is the synovial fluid, right? Let me take another color, right? Synovial fluid. What happens, guys? Now the synovial fluid can enter these subchondral microcracks, right? Synovial fluid can enter through these microcracks and they can reach the bone. Now, in a healthy joint, right? In a healthy joint, is there direct contact with the inner layers of the bone and the synovial fluid?
No.
No, right? No, right? Firstly, there is a nice cartilaginous barrier, so it is not allowed to go there, right? But now what is happening? Synovial fluid seeps in through these micro cracks, right? And you all know, guys, synovial fluid at these stages, usually there is inflammatory materials, right? Debris and everything. All of these things can get into these subchondral micro cracks, right? What can happen, guys? Look at this. These ones, there will be cystic changes occurring, right? Something like this you all can draw, right? Right, something like this. From these micro cracks, there will be cystic lesions evolving, guys, right? Something like this, right? Cystic lesions, right? Let me draw. Who is inside these cysts? What is a cyst, guys? A cyst in our body is, what is a cyst? Can someone define a cyst? for me? Yeah, it is basically a fluid-filled cavity. It is a fluid-filled cavity. Now, in these cysts, what is the fluid filled here? Synovial fluid. Synovial fluid. Now, what I want you all to know here, guys, some of these, now you all can see all of these that we have drawn, they have a nice communication with the synovial fluid, right? That's how we have drawn it. But with time, guys, some of these can actually heal, right? The overlying cortex can heal, right? So it will, some of these will still have that open communication. Most of them will actually heal. Now these ones have the open communication, right? The other ones, guys, they will just appear as cysts because that communication channel will be healed off. It will heal, right? So it will appear like this eventually, right? Okay. What is inside these cysts? Our synovial fluid, not just the synovial fluid, there can be any inflammatory substances, right? Any cytokines, these things also can be stuck here, right? So these are, what do we call these, guys? We call these subchondral cysts. Subchondral cysts, right? Subchondral cysts. Okay. Subchondral cyst formations, right? All of these, why? Because the bones are rubbing against each other, right? Cartilage worn off, bones are rubbing against each other, micro damage, right? Okay, so subchondral sclerosis, subchondral cysts, right? Okay, now we've discussed a few of the major pathologic changes, right? We saw loss of joint space, we saw thinning of cartilage, right? Loss of cartilage, fissuring and fibrillation of cartilage, all of those, right? All of these changes, right? Clear? See, you're writing down. We have a couple of. Right? Oh, good. Right. Okay, look at this, guys. Now, that's that, right? We'll leave it at that. We'll come back to it, right? Now, we'll look at this inflammation a little. Remember, here we had some inflammation, and here also we had some inflammation, right? Inflammation, right? We had synovial inflammation as well as some subchondral bone or subcortical bone inflammation, right? Subchondral bone inflammation. What is happening here, guys, with this inflammation? You all know it is accompanied by inflammatory cytokines, right? Especially, guys, and also whenever there is inflammation, there can be what? There can be pain, right? There can be swelling, right? And all the cardinal signs, right? Loss of function, all of these can be there. What I want you all to know, guys, the main inflammatory cytokines involved, we have a couple of cytokines to talk about, right? One is vascular endothelial growth factor, right? This will also be released. We'll talk about it, right? Then we have the more common ones, interleukin 1, right? Interleukin 6, right? And TNF alpha. What I want you all to keep in your mind, guys, right? There is inflammation. This is why we call this biomechanical, but it is never as serious as rheumatoid arthritis, right? And other inflammatory arthritic conditions. Inflammation can be there, right? Never as serious as inflammatory arthritis conditions, right? Okay. So when you all are discussing those chapters in the future, in the upcoming lectures, keep that in mind. Osteoarthritis has mild inflammation, right? Mild inflammation. Right. Look at this, guys. Now, look at this. Let me make this fill a little bit. You all can keep the drawing, no problem. Right. Okay, look at this, guys. This interleukin 1 will keep vascular endothelial growth factor for a while. Interleukin 1, guys, interleukin 1 has a direct effect. It has a direct effect on chondrocytes, and it can inhibit collagen. Type 2 collagen synthesis can be inhibited. Type 2 collagen synthesis can be inhibited, right? Type 2 collagen synthesis inhibition. Okay, right? Type 2 collagen. So one of the most important parts of our metrics, their production is now going to be inhibited. Previously, what did we see? Their production was reduced here, guys. Do you remember? We saw production reduced, right? Now, production is going to be completely inhibited with the inflammatory cytokines coming in, right? Type 2 collagen synthesis production drops drastically. Then all these three guys, interleukin 1, interleukin 6, and TNF alpha, they have a stimulatory effect on the synthesis of certain metalloproteases. Certain metalloproteases. Don't worry about the name. I will tell you all. Right? Okay. Here is the name. When I tell the name, you all will all be very happy. Look at this. Right? The example I want you all to know, aggrecanase. Aggrecanase. What does it do? What does it do? Tell me, just from the name.
Destroys the aggregants.
Destroys aggregant, right? So what do we? There are other metalloproteinases, but we don't need to talk about them. There are actually a lot, right? We don't need to talk about those. What is happening? Look at this. Collagen synthesis inhibitor, type 2 collagen synthesis inhibitor. Aggrecan is also going to be destroyed. Now, what I want you all to do, right? Take an arrow like this, and join it to those two, and put an inhibition sign here, right? This is why I told you all to keep the space, right? Nothing else, just two arrows, right? Right. So there is going to be, you can put a big inhibition sign, right? Both of these, type 2 collagen reduced, aggrecan reduced, right? Now the condition is getting a little bit serious, guys, right? Okay, type 2 collagen synthesis inhibited, right? Aggrecan production further reduced, right? Because of this mechanism, right? Now, look at this. Okay, guys, we'll come back to this bone on bone appearance. Don't worry, this entire picture will make sense once we complete it, right? We are jumping from place to place because why we said this is not a step-by-step process necessarily. We'll see, right? We'll come back to this bone on bone appearance. What did we say? This one results mainly in subchondral sclerosis and subchondral, what's the second one? Subchondral sclerosis and what? Subchondral cysts. Cysts. Guys, don't forget these names are very important for your MCQs. Okay, right. Then we'll come back to this bone on bone appearance. Look at this, guys. We'll take another arrow here upwards, right? Okay, look at this. Now there is literally no cartilage. There is literally no cartilage, right? There can be a very little bit, but almost negligible amounts of cartilage in this joint, right? Bone on bone, right? Now, what should the body try to do? What should the body try to do? To try and produce new cartilage, correct? To try and produce new cartilage. So you can put an arrow. You can say the body tries to produce new cartilage, right? Attempts to produce new cartilage, right? But, right? Put a big but there, right? First thing, right? But what do you think about the joint space? Is there enough joint space to produce new cartilage? No, joint space is severely narrow. Joint space severely narrow, right? And the second one, can the body now produce type 2 collagen? Can the body now produce type 2 collagen? No. That is the second one I want you all to know. Type 2 collagen cannot be synthesized. Cannot be synthesized. Right? Type 2 collagen cannot be synthesized. Right? Let me put this to a little bit up here. Right? Right? Now look at this, guys. Joint space is severely narrow. Type 2 collagen cannot be synthesized. Now what happens when the body attempts to produce cartilage is this, guys. Look at this. Look at this very carefully. When the body tries to produce new cartilage, first thing, because the joint space is very narrow, it will produce some cartilage, but those cartilage will go outwards from the joint space, right? They will start growing outwards, guys, because in the joint space, there is not enough space for them to grow, right? So these cartilage spurts grow outwards at the edges of the joint, at the edges of the joint. Then the next thing, guys, type 2 collagen cannot be synthesized. What do you think these collagen is that this cartilage was produced? Our chondrocytes, guys, look at this. Our chondrocytes have the capability to produce the other types of collagen as well. But wherever necessary, they adapt to produce. So for example, in a hyaline articular surface, they produce hyaline cartilage, right? Because that's what they're made to do there. Now, since type 2 collagen cannot be synthesized, what do chondrocytes do? They switch to type 1. They're like, okay, cartilage is cartilage. I will produce something, right? I want to only produce cartilage. I don't care what type of collagen is there. I will produce. So he switches to type 1 collagen. If you zoom into one of these and look, guys, right? If you zoom into one of these and look, this is a completely different structure from this. Looks something like this, guys. A very neatly organized. Do you remember our hyaline cartilage? Right? It was haphazard. There was type 2 collagen everywhere. There were centipedes, the proteoglycans everywhere. Chondrocytes were everywhere. But this structure, if you zoom in and look, it is a very neatly organized structure. The cells are also nicely in a row like this, right? Very neatly, nicely organized structure. This is, guys, this is type 1 collagen, type 1 collagen, right? And this forms, what is this type of cartilage? This is not hyaline cartilage. This is, guys, fibrocartilage, right? This is fibrocartilage, okay? Fibrocartilage, okay? Fibrocartilage is a much stronger, much less shock absorbing type of cartilage, right? It's a much strong one, much less prone to malleability, right? It can absorb a lot of shock, but it is very hard in nature. It is very rigid in nature, right? Okay, this is there in areas like your pubic symphysis, guys, right? Yeah, in your spinal cord, in the intervertebral spaces, right? So these are very hard, a very hard type of cartilage, fibrocartilage. Now look at this. These ones, guys, fibrocartilage is being, we call these guys fibrocartilage spurs, right? Fibrocartilage spurs, right? Spurs. Now let's go a little bit down to our cytokines. Remember our VEGF, vascular endothelial growth factor, right? What happens is, guys, you all know, in the bone itself, in the bone usually has a nice blood supply. Bone usually has a nice blood supply. Do cartilages have a good blood supply? No, cartilages are usually avascular structures. But now what is happening, guys? VEGF comes here, right? You all can draw another line there, all the way up here. VEGF comes here, vascular endothelial growth factor, right? Vascular endothelial growth factor comes here, guys, and it stimulates new vessel formation towards this subchondral region, new neovascularization, new vessel angiogenesis, right? And what happens? Some of these vessels grow into this cartilage, this fibrocartilage structures as well. What happens when cartilage receives blood supply?
Ossification.
Ossification.
They ossify, right? So after a while, guys, how will it look like? Initially, it was this nice bluish color, cartilaginous substances. After a while, right, if you look at the bone, it will look completely bony, right? On X-ray, guys, they look like extensions of the bone itself, right? We call these osteophytes, right? Osteophytes, okay? Osteophytes, right? Osteophytes, okay? Everyone understood that, right? Okay. Now, look at this, guys. One more extra point to add here. Now, this is the basic pathophysiology of osteoarthritis. We are almost done. Look at this. One more small point to add here, guys. Put it as a note. We saw this joint space narrowing, right? And this fissurings and fibrillations, right? Let's look at this fissuring and fibrillation here, right? You can put it as a note here, guys. Note, right? They have found, especially in the knee joint, when this fissuring and fibrillation occurs in the knee joint, right? There can be, right? Some, now you all know, guys, this area looks something like this. Look at this, right? Something like this. And I will exaggerate the fissures. It will look something like this, exaggerated fissures, right? In these fissures, guys, there can be some substances depositing, right? Some substances depositing in these fissures, right? In these fissures. What are these, guys? Right? Calcium pyrophosphate. Calcium pyrophosphate. Right? Right? This is not very common, but in the knee osteoarthritis, guys, sometimes these calcium pyrophosphate depositions can be seen, right? You have to differentially diagnose because you all will learn something similar in a condition called pseudo gout, right? Something called pseudo gout. Now it's coming up, okay? That lecture is coming up, right? Just note in the osteoarthritic knee joint, especially when fissuring and fibrillations occur, there can be some calcium pyrophosphate deposition. Okay, right? Okay, right. So this is the pathophysiology. What do I want to stress here? Now look at this, guys. What is the final step we talked about here? What is the final step in this entire process? What did we talk about? What is the final one? What did we talk about?
Calcium.
Yeah, osteophyte. This is the last one that we did, right? But even very early osteoarthritis patients, some patients, when they present to you, they can already have osteophytes, right? What does this tell you? This is not a step-by-step process. Osteophyte formation is not, we cannot say it is the last step of this process, right? Any of these can be seen in any stage that the patient comes in. It's just that the severity will be different. For example, if we consider osteophytes, right? If we consider osteophytes, in a patient with advanced osteoarthritis, you will see a lot of osteophytes and large osteophytes, right? Same with this subchondral cysts, right? You will see a large amount of cysts. You will see very large size of cysts, right? In the advanced stages. But even a patient at very early stages coming to you can still have some cysts. It will be smaller in size, much less in size, but still can have cysts, can have subchondral sclerosis, can have osteophytes. All of these can be there. Okay, did everyone understand that? Right? So the pathophysio guys understand the mechanisms, right? It's okay to remember it kind of like a story, step by step, but just know it is no, you cannot say an early patient will not show osteophytes. An early stage patient will not show sclerosis. You cannot say. Okay, keep that in your mind. Very important. Right? Right. Then guys, we are done with today's class, right? Tomorrow we are going to the diagnostics and treatment. Tomorrow's session is also free, right? If you all have any friends who are interested. Now I will just show you all a small video, right? Of just for you all to get this picture solid in your mind. Just watch this. It's a 2-minute video. Let me stop the share here. Right. Give me a second, guys. Right. Look at this, guys. So in this video, right, there is no audio, right? I will explain certain things, but I want you all to appreciate the structures and get the 3D structure into your head, right? Of these osteophytes, of the subchondral bone. This is a video of osteoarthritis of the knee, right? They take you through all the stages. Let's watch it. Nice. Yeah, there we go. Right. Guys, can someone tell me in the chat if you all can see my video? I can't see you all as well. Yes or no in the chat? Yep. Okay. Good. Good. Okay. Right. Look at this, guys. Wait. Right. So this is the knee joint. We are looking at osteoarthritis of the knee joint. Okay. So they are just labeling the parts, right? Look at this, guys. Now the joint is bathed with this synovial fluid within the synovial membrane, right? This glassy structure is the cartilage which is inside, right? Look at it. It looks like porcelain. It's very shiny, very smooth, right? Okay. This is how in a healthy knee, guys, right? The articulating surfaces, right? Yeah. Okay. Yeah, full range of motion without pain. Okay. Right. Look at this, guys. Mild osteoarthritis. Okay. Now appreciate these are the fissures, guys. These are the fissuring and fibrillations, right? Right. Now in the 2D diagram, we drew it just like lines, right? Inverse. Now I want you all to imagine this 3D architecture, right? This is how they look, this fissuring, right? And fibrillations. Okay. And you can see these osteophytes, right? These can be in the initial stages much smaller, right? We will see in the later stages, they show that these are very much larger, right? Okay. Yeah, the treatment, don't worry, we will discuss this tomorrow fully, right? Then the moderate one, guys. Now see, they show the synovium a little bit in yellowish appearance, right? The synovium, they are trying to show some inflammation. They're trying to show some inflammation. And look at this osteophytic formation, and this cartilage wear is much more serious now, guys, right? Okay. Right, this is they're showing you the subchondral bone. Yeah, this is damage to the subchondral bone. There is osteophytes can even start in the subchondral bone itself, guys. Okay, right? But usually they are in the periphery, in these corner regions, right? See, osteophytes grow in number and size. This is what we said, right? And look at the movement, guys. Can you see the movement? Due to the strong, heavy friction forces, the movement is now not smooth, right? This will give rise to pain, right? We will talk about the nociception and everything tomorrow, right? And this is severe, guys. Look at it. Firstly, there is severe inflammation, right? In the joint space, it's much more yellowish in color. And look at the cartilage being destroyed, right? And look at the osteophytes, right? Large numbers of osteophytes and very large osteophytes. Joint space narrowing also, I appreciate that as well, right? Okay. All right. Yes, there is going to be pain during movement. Right? Look at the movement, guys. Now, see the cartilage has, there is no cartilage. It's bone on bone, bone on bone. Bone is touching with bone, right? So there is going to be inflammation, right? There's going to be pain, a lot of pain, right? And the movement is not smooth, right? Yeah. So that's it. Okay. Right. So I hope everyone understood today's content, right? We are done with the underlying mechanisms. Tomorrow, we need to talk only about the diagnostic side. So we're going to talk about the clinical diagnostic side and the labs. We're going to talk about a lot of x-rays, right? Tomorrow's session is also free. If you all have any friends who want to join, ask them to join. Okay. If you all have any question about today's class, right? Drop me a message, right? Preferably before tomorrow's class so you all can clear up any doubts. Right? Okay, guys, then that's about it for today's session. I will see you all tomorrow again at the same time. I will put a notice. Okay. Okay, guys, good night. See
Thank you so
Thank
much.
you.
Right, no problem.